Okay, good morning everyone. There's a slight change in today's topic. Actually, it's supposed to be inflammatory bowel disease, but this is actually next week topic, so we'll be starting with this. Today's topic will be irritable bowel syndrome. It's only 105 people over here. Any more expected? Maybe it is the same. Today's topic will be dealt along these lines. Initially, we'll be dealing with the definition, followed by the pathophysiology, and then the clinical features, investigations, what is the diagnostic criteria for irritable bowel syndrome, and what are the red flag signs, that is the alarming signs what you need to take care of, like you need to further investigate the patient, what are the red flag signs, and what is the treatment of irritable bowel syndrome. Coming to the definition, it is a functional disorder of the GIT characterized by there will be abdominal pain or discomfort and there will be altered bowel habits without any organic. You can't find any organic cause. Means they can't be any. They will not find any structural cause. Neither you will find any infective cause. Neither in the blood test you will not find any abnormalities. So it's a benign chronic symptom complex of altered bowel habits and abdominal pain. This is the definition of irritable bowel syndrome. Coming to the pathophysiology, exact cause is not known, but many theories are proposed. Among these theories, these are the 5-6 things which are widely accepted. Gastrointestinal motor abnormalities. Gastrointestinal motor abnormalities means usually in this 25 to 75% of these patients you will find altered GI motility. That is quantitative alteration in the GI motility will be there when you compare with normal healthy people. There are two types, IBS where constipation is predominant and IBS where diarrhea is predominant. In patients with diarrhea, who will have predominant diarrhea symptoms, they'll be having rapid jejunal contraction waves will be there. So rapid colonic contractions waves will be there. So the intestinal transit time has decreased. And also there is accelerated colonic transit and also rectosigmoid motor activity. So these patients will be presenting with diarrhea. But in the patients who have predominant constipation, they have decreased GI motility will be seen in these patients and reduced number of colonic contraction waves will be seen. The next point will be, next proposed theory is the visceral hypersensitivity. Visceral hypersensitivity means as and when we take the food, there will be mild intestinal distension will be there. So the intestinal wall will be distended, and so there will be increased sensory responses to this visceral distension. So this will cause pain. That is visceral hypersensitivity. Coming to that central neural dysregulation. Central neural dysregulation means here our GIT is affected by our emotional status also. Indirectly, the brain is controlling the emotional disorders and also the stress and also the GI activity. An example for this is when you take an MRI, when there is a colonic distension, then you can see increased activity in the mid-cingulate cortex. That will show that this will show more activation in the IBS patients. Okay. And next one will be the abnormal psychological features. Abnormal psychological features means around up to 80% of the IBS patients, you will have other psychiatric manifestations. There will be emotional stress will be there, excess worry will be there, or somatization disorders will be there in the patients, or patients can have neurosis. So in 80% of patients, you can see abnormal psychiatric features. Altered intestinal flora is also seen in more in IBS patients. Means there is bacterial overgrowth can be associated, seen in IBS patients. The other one is just 1 second. There's some technical issue. Just hold on. There's a technical issue. 1 second. Where is this one? Just 1 second, hold on. I'm really sorry for this. Just bear with me. 2 more minutes. We'll get back to the class. Okay. After, hope you are able to hear me. We'll wait till the person comes. So far, we have completed the definition and also the pathophysiology. In the pathophysiology, we have seen the altered GI motility, followed by visceral hypersensitivity, and then CM. ఇదేదో వచ్చి ఆఫ్ అయిపోయింది. Okay. Followed by the altered intestinal flora, that is the bacterial overgrowth will be there, and the abnormal serotonin pathway. This serotonin is usually important for the visceral sensations, and then post-infectious IBS. Post-infectious IBS, it can be seen in certain post GI infections caused by Campylobacter, Shigella, Salmonella, and also immune activation and mucosal inflammation. Coming to the clinical features, it is most common presentation will be seen in the age group between 20 to 40 years, and then definite presentation it will be below 45 years of age. And coming to the gender predilection, females are more prone than males, the ratio being 3:1. What is the most common clinical feature? Most common clinical feature is the abdominal pain or the discomfort which these people will be complaining. This pain also, abdominal pain also, it's more like localized in the lower quadrant of the abdomen. That it can be in the right iliac fossa or the left iliac or in the hypogastrium. And this pain, main feature of this pain is it increases with stress and also poor sleep, and after intake of food also the pain increases. What are the relieving factors? Like after passing stools or flatulence, but the relief of the pain is only temporary. And the next important one, apart from abdominal pain, you'll have altered bowel habits. Abdominal pain, having this abdominal pain or discomfort is the most common symptom you are able to see. But most consistent feature will be altered bowel habits. Based upon what type of bowel habits these patients are presenting, there are 3 variants. IBS, where you can see the constipation is the predominant feature, or IBS, where you can see the diarrhea is the predominant feature, or the mixed IBS one. IBS, where you're having constipation as the predominant feature, these patients, they'll have spastic colitis. Means they'll be having chronic abdominal pain and constipation. In patients where you're having diarrhea as a predominant one, these patients will be presenting with intermittent watery diarrhea. Usually abdominal pain will not be present in these patients. And in a mixed pattern, you will have diarrhea alternating with constipation. In this mixed pattern also, which is the most common bowel habit type, that is constipation alternating with diarrhea is the most common pattern. You're having diarrhea. If it is IBS with the diarrhea predominant, how would that diarrhea be? The patient will be having frequent episodes of defecation. Usually it is painless. In the constipation time, patient can have tenesmus. But in this diarrhea predominant patients, usually this diarrhea is painless diarrhea. They'll pass only low volume stools and very frequently they'll be passing. So, and almost very rare or never at night time symptoms will not be there. Small volume, many type, frequent stools. There will be sense of incomplete evacuation will be there. In constipation predominant one, usually it will be like pellet-like stools. That is, you'll have pencil-like or ribbon-like stools where it will have narrow caliber. And constipation, proctalgia, abdominal pain will be associated. The stools are hard with a narrow caliber and accompany the passage of large amount of mucus. And also another clinical feature will be like gas. Patient will be complaining of flatulence. This is more common in the females. Postprandial tenesmus is more common due to exaggerated gastrocolic reflex. This is most common seen in females. Also, some of these patients may be presenting with GERD symptoms, also like ABD symptoms, and also nausea and vomiting. What are all the other extra-intestinal symptoms? Patient can present with headache, backache, fatigue, myalgia, increased urinary frequencies. Other important thing is while examining these patients, we have to check for, we have to ask for symptoms of psychiatric manifestations and check for symptoms of psychiatric manifestations. Upon examination, these are so far we have seen the clinical features. Among the clinical features, the most common one will be the abdominal pain. Most consistent feature will be the altered bowel habits. Apart from that, you have described the uh, you have given description about the stool, or you have added given description about the other add-on features like flatulence will be there, or how the stool consistency will be there, or what are the predominant features in constipation type, what are the predominant thing in diarrhea type. And on examination of this patient, usually on examination, you will not find anything abnormal in this patient, except for sometimes there might be lower abdominal pain will be there, or you can, and very at rare times you can palpate the sigmoid column. In IBS constipation predominant type, when you go for rectal examination, there will be contraction of the puborectalis or decreased descent of the pelvic floor when simulating a bowel movement. What are all the investigations? Uh, as like other diseases, routine investigations, complete blood picture needs to be done along with ESR. And then stool examination. You will examine the stool for presence of ova, cyst, parasite, leukocyte, or occult blood. And then sigmoidoscopy. If you do sigmoidoscopy in these patients, usually it is normal. While trying to advance the scope, you can find some resistance at the rectosigmoid curve, because there will be these constipation type patients will be having spastic colitis. There will be marked activity of the bowel, and while negotiating the scope, you can see abundant amount of mucus. Next, other investigation will be colonoscopy. Colonoscopy, why you want to mainly do? In an elderly patient who is presenting with more than minimal bleeding, means your minimal bleeding, constipation, you can have minimal amount of bleed can be seen. This can be due to the local cause. But if it is more than minimal bleeding, you are not suspecting it is because of this. There is something more than that which is causing the excessive, which is causing the bleeding. Then you have to exclude mainly in elderly patients where malignancy percentage chances are more. So you have to do colonoscopy to exclude colorectal cancer in elder patients. Barium enema. Barium enema usually it is normal. Mainly what you can see is spasticity of the sigmoid colon. Exaggerated hostile markings. In the colon, you will have the hostile hostrations will be there like this. Like you can see the like this hostrations will be there. Exaggerated hostile markings will be there, and tubular appearance of the descending colon. In persistent diarrhea type, someone is having persistent diarrhea. What are all the other investigations you want to do? Means to exclude the other diseases. That is, what are all the differential diagnoses? You can have your thyrotoxicosis. You want to eliminate, exclude thyrotoxicosis. So you'll be doing your thyroid profile. And other thing is profuse diarrhea. It could be just a lactose intolerance. So you have to test if the patient is having lactose intolerance. How will you test for that? I think you would malabsorption syndrome was dealt in the last class. Um, how do you test for lactose intolerance? You will be checking for the hydrogen breath test. That is made because in this lactose intolerance, patient will be having lactase enzyme deficiency. So what will happen? This lactulose, after giving oral lactulose, this lactose will not be digested. So the colonic bacteria will be acting upon it. And then, so there will be more amount of hydrogen in the breath. That is hydrogen breath test. And other differential diagnosis which you want to exclude should be celiac disease. How do you check for celiac disease? And also for lactose tolerance test, you also can check for the, in the jejunal biopsy specimens, you can check for the lactase enzyme levels. Other thing will be the celiac disease, to exclude the celiac disease. What are all the things? One is the gold standard one will be definitely a biopsy that will diagnose this celiac disease. Apart from that, what are all the serological tests which can help in diagnosis of the celiac disease? Serological tests can be like this, anti-gliadin antibodies, IgA, IgG anti-gliadin antibodies, anti-endomysial antibodies, anti-tissue transglutaminase antibodies. These are all the serum tests which you want to do to diagnose celiac disease. These are all the differential diagnoses in the case of persistent IBS with persistent diarrhea type. And coming to the most important, this is the Rome 3 diagnostic criteria. Rome 3 diagnostic criteria means in this patient, before the diagnosis, the symptoms will be there from the past 6 months. But there will be recurrent abdominal pain or discomfort at least for 3 days per month in the last 3 months, associated with 2 or more of the following. What are all the following? Improvement, the pain is improved with defecation, or onset associated with change in frequency of the stool, or onset associated with change in the form of the stool. This is an important question for you. Rome 3 diagnostic criteria for irritable bowel syndrome. This slide is very important. Coming to the next part, what are all the other additive symptoms which can help, which will help to arrive to a diagnosis? That is symptoms that support the diagnosis of IBS. You will be having abnormal stool frequency, that is less than or equal to 3 bowel movements per week or greater than 3 per day. These are all the supportive things which will help in the diagnosis. Abnormal stool form, that is lumpy hard stool or loose watery stool will be there. The other one is defecation straining, and patient will be having sense of incomplete evacuation. Urgency will be there. Feeling of incomplete bowel movement. Passing mucus will be there. Bloating or abdominal distension. These are all the other symptoms which help support the diagnosis of IBS. So apart from this, what are the red flag signs of IBS? Red flag signs means alarming signs, where you need to definitely find out if any other underlying diagnosis is there. More than minimal rectal bleeding means you wanted to rule out a malignancy in these patients. Unexplained more weight loss, excessive weight loss, unexplained iron deficiency, whether any other malabsorption is associated with this. Nocturnal symptoms. Usually nocturnal symptoms are very rare or never seen in these IBS patients. Fever. Usually fever is never associated, but if fever is there, you have to consider, you have to check for any other underlying disorder. Family history of selected organic diseases like colorectal cancer or inflammatory bowel disease or celiac flu. Other malabsorption syndromes have to be ruled out. These are the red flag signs of irritable bowel syndrome. Coming to the treatment part. So far we have seen definition, the pathophysiology. Pathophysiology usually it is not clear, but these are all the proposed theories, followed by the clinical features we have seen, and then the investigations, the diagnostic criteria, and the red flag signs. Following that, the most important is, because in and around in our practice we'll be seeing majority of mainly more IBS cases. So the treatment part is also important. The first and foremost is whenever you see a patient with symptoms suggestive of IBS, patient counseling and dietary alterations. First, you need to inquire the diet of the patient, and advising dietary modifications is the first and foremost treatment protocol. And the further treatment depends upon whether it is constipation dependent, constipation predominant IBS, or whether it is diarrhea predominant IBS. First and foremost being the patient counseling. You have to reassure with the patient, and then you have to explain the patient that it has a benign prognosis. So it's functional. Reassurance is the most important thing in this patient. Coming to the dietary modifications, like it can be majority of the diet protocol will be almost the same for many patients, but there will be individual food items also which have to be avoided as per the patient if they have any precipitated symptoms. So dietary modification will be avoid foods that precipitate the symptoms. Dietary restriction of fermentable carbohydrate, that is put a low FODMAP diet. FODMAP means fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So low FODMAP diet. Exclude foods that increase the flatulence like beans, celery, carrots, raisins, bananas, wheat germ, bagels. Alcohol and caffeine is the most common. Like routinely, we'll be seeing majority of the patients take alcohol and caffeine, and you have to advise them to take a minimum of high fat foods. Means lessen the amount of fatty foods. And most important thing along with dietary modification is the regular physical activity. So the initial baseline important factors, treatment protocol factors are first being the reassurance of the patient, and then followed by dietary modifications like avoid foods whichever is precipitating the symptoms, and most important thing will be advise regular physical activity for these patients. The next further treatment depends upon whether the patient is having constipation as predominant or diarrhea as predominant. For patients where you have constipation predominant IBS, so patient is having constipation, what you want to do, you want to increase the bulk of the stool. So stool bulking agents, that is advise him to take high fiber diet. Other bulking agents like hydrophobic colloid bran. What will happen, these will increase the content of the diet and they'll delay the colonic transit. Even after fiber diet, if still symptoms are persisting, add a bulk laxative like methyl cellulose, isabacol husk, psyllium fiber diet, corn fiber. If though you are giving high fiber, still it is not working out, try osmotic laxatives like polyethylene glycol, lactulose, magnesium oxide, or secretory stimulators like lubiprostone can be tried. These are the bulk stimulating. First, most important dietary modification should be, you should advise the patient to take high fiber diet. Next, in these patients, motility is decreased. So what you want to do? In patients with constipation, there is decreased contraction waves. So try to stimulate the contraction, that is prokinetic agents. 5-HT4 serotonin receptor agonist, it's a prokinetic. Tegaserod, it stimulates the intestinal peristalsis, but it is withdrawn because of cardiovascular side effects. Cisapride, mosapride also not much useful. The other thing is antispasmodics. In constipation patients, the most important is along with you're having abdominal pain. So relieve that pain. So you can give synthetic anticholinergics, that is dicyclamine 10 mg TID or mebivaline 135 mg TID can be given. The other important thing, IBS patients, 80% of IBS patients you are having associated, means along with that you are having psychiatric manifestations. So antidepressants also play an important role. Patients with intractable symptoms give tricyclic antidepressants, amitriptyline or desipramine 10 to 25 mg at bedtime. Other important clinical feature, means symptom the patient will be complaining will be flatulence. What is the anti-flatulence? What are the advices you can give it to this patient? You can advise the patient to chew slowly, eat slowly, avoid chewing gums, avoid carbonated drinks. And then antibiotic like rifaximin 400 mg TID, it will also help in relieve bloating. Other thing will be chloride channel activators like lubiprostone. This lubiprostone will activate the chloride channels in the intestinal epithelial cells. So what will happen? Chloride channel is activated. So the sodium and the water will be moving into the lumen of the intestine, and then the content will be more, and then it improves the bowel function. So this is important in constipation predominant IBS. Next, coming to the diarrhea predominant IBS. Means this patient is having increased frequency of stools, and patient might have loose watery stools also, increased frequency loose watery stools also. So you advise the patient to avoid high fiber diet. In constipation one, you want to give more fiber so that there will be bulk of the stool. In this patient, already the patient is having increased frequency. So advise to avoid legumes and high fiber diet. What are all the anti-diarrheal agents you can advise? Anti-diarrheal agents like loperamide, 2 to 4 mg up to 4 times a day. The maximum dose you can give is up to 12 mg per day. And cholestyramine disease, that is bile acid sequestration binding agents, 4 grams, that can be given 4 to 6 times per day. Other thing, serotonin. As like I told in the initial one, serotonin plays an important role in the visceral sensitivity. Serotonin acts on the 5-HT3 receptors and increases the sensitivity of afferent neurons of the gut. So allosterone, it reduces the abdominal visceral pain. Means it will decrease the, you're blocking, there's an antagonist. So that abdominal visceral pain will be decreased. It will help in rectal relaxation, increases rectal compliance and delays colonic transit. Thus, the increased contraction waves can be tackled. Antispasmodics for pain relief. And what are the antibiotics you can give? Rifaximin 400 mg BD for 5 to 6 weeks. Probiotics. Probiotics role is still under investigation. Don't know how far, but some efficacy is found. Bifidobacterium and Saccharomyces boulardii. Uh, Esomeprazole. It's a kappa opioid receptor agonist, which is in trials for the treatment of irritable bowel syndrome. So, your take-home message. This flowchart will be your take-home message. Management of irritable bowel syndrome means you can see what is it. Irritable bowel syndrome proved. First thing, treatment is reassurance. Why you want to reassure the patient? Because there is some psychological association with there is there. Why you want to go for dietary modifications? Because dietary modifications, like dietary modifications depend upon whether it is constipation predominant or diarrhea predominant IBS. So in patients who are having altered bowel function is there, constipation predominant. So you want to give stool bulking agents. After giving stool bulking agents also still there are symptoms. Then you want to give bulk laxatives, osmotic laxatives or serotonin receptor antagonists and prokinetics. Still there are persistence of symptoms, you want to give antidepressant drugs. And then in following the center column in the flow chart, if there are altered bowel function and it's diarrhea predominant, avoid legumes and high fiber diet. You want to give anti-diarrheal drugs, loperamide, cholestyramine, 5-HT3 receptor antagonists. 50% of the patient, initial reassurance and dietary modification will work out. Their symptoms will resolve. Other symptoms to tackle the bloating, like anti-flatulence therapy can be tried, smooth muscle relaxants, serotonin agonists and antagonists, abdominal pain, TCS, the tricyclic antidepressants, selective serotonin reuptake inhibitors, serotonin agonists and smooth muscle relaxants can also be given. So this is your take-home message. This flowchart is your take-home message. And in this table, what I want you to keep in mind is the alarming features. That is the red flag signs. Elderly patients, family history of colonic cancer or family history of IBD or family history of any other malabsorption syndromes. Investigate this patient thoroughly. And then if there is fever or unexplained excessive weight loss or more than minimal bleeding, even that patient has to be investigated. And nocturnal symptoms are there for this patient. Even that patient has to be thoroughly investigated. And on examination, if you find any abdominal mass or associated skin abnormalities or lymphadenopathy or arthritis are there. So this arthritis and all will help in your, you will find it in your inflammatory bowel disease. Next, once you find these red flag signs, investigate these patients thoroughly, and then to what you want to say, to exclude lactose intolerance or celiac disease or IBD or any other malignancy. So these are the tests to be done. I think that's the end of the class. Okay, we have finished the definition, pathophysiology, clinical features, investigations, diagnostic criteria, red flag signs, treatment. This irritable bowel syndrome will be mostly a 4-mark question. And in detail, diagnostic criteria also can be Rome criteria. Rome 3 criteria is also a 4-mark question. Treatment part also is important. As such, there's a very small topic. You can put forward any doubts if you have in the chat box. There's a chat box. Is it used for bloody stools? Rule out infectious cause. Someone had asked me, loperamide, is it used for bloody stools? Usually no, you have to thoroughly investigate if it is an infectious cause. You can't give loperamide in an infectious cause. Any doubts you can put in the chat box. As such, this is a very short topic. Actually, your today's topic is inflammatory bowel disease. That will be inflammatory bowel disease. That will be dealt with the next week probably. So what we want you to do is read the inflammatory bowel disease part. That is your essay question actually. So ulcerative colitis and Crohn's disease, or what are the complications of ulcerative colitis? That itself is a 4 marks question. Or the entire inflammatory bowel disease is a essay question. Any more questions? I'm happy to take your questions. Shall I ask questions to you then? If you are not asking, then I'll try to pick up someone. Oh my God. Okay, then we'll end the session over here. It's too early to end. Okay, if no more questions, then we'll end the session. That's it for today. Hope you have a nice day and be prepared with inflammatory bowel disease in the next class, next Tuesday class. We'll update you regarding when it would be conducted. Okay, then thank you.